Hello, everyone. Welcome to Trauma from an Intersectional Perspective presented by ISTSS. We're so glad you've joined us today. My name is Holly and I will be your staff host for today. Please note that all lines have been muted in order to ensure high quality audio, and today's webinar is being recorded. If you have a question for the presenters, you can enter it at any time using the Q&A feature. That is the best way to get in touch with the presenters to answer your questions. There's also a chat feature, but that's more for comments. So we would appreciate it if you'd use the Q&A feature to ask questions that you'd like for the panel to address. Today's webinar was organized by the Sexual Orientation and Gender Diversity Special Interest Group. ISTSS has 25 different special interest groups that we invite members to take an active role in. Please visit our website to see a list of the SIGs and to request to join a SIG that might line up with your interests. Visit the ISTSS website for the latest information on the upcoming virtual annual meeting. Read the most recent Stress Points articles, find out about upcoming publications, check out the available public resources, and see today's just published installment of Friday Fast Facts. And now I will introduce today's distinguished moderator, who will in turn introduce our esteemed panel of speakers. Debra Kaysen is a professor at Stanford University in the Department of Psychiatry and Behavioral Sciences, and is a research psychologist at the Dissemination and Implementation Division of the National Center for PTSD at VA Palo Alto. In addition, Dr. Kaysen is the current president for the International Society for Traumatic Stress Studies. Dr. Kaysen's area of expertise is increasing access to care in the treatment of PTSD and related disorders across settings and populations. At this time, I will turn it over to Dr. Kaysen to start the discussion on trauma from an intersectional perspective. Welcome, everyone.
Holly, thank you so much for that lovely introduction. And first, I want to thank the Sexual Orientation and Gender Diversity SIG for all of their efforts in organizing and hosting this important webinar, for bringing together this incredible group of speakers, and for all of their efforts addressing trauma within gender and sexual minority communities. For those who might be interested in learning more about these types of issues, every 6 months, the SIG student co-chairs compile and share through the ISTSS SIG listserv articles focused on trauma experiences among the LGBTQA communities. And during Pride Month, they contribute to Stress Points, which is our newsletter, and to the ISTSS blog on topics centering around the lived experiences of LGBTQ individuals to bring awareness to the broader trauma community. Now, let me introduce our esteemed panel. Dr. Juliet McClendon is a clinical psychologist in the Women's Health Division of the National Centers for PTSD at VA Boston, and is an assistant professor of psychiatry at Boston University School of Medicine. She studies the role of racism and discrimination in shaping racial and ethnic mental health disparities, and the identification of intervention approaches that can mitigate the impact of racism-related stress and trauma on health. And we could not be more lucky than to have you on this panel.
Thank you for having me.
You're very welcome. Dr. Soraya Sadat is a distinguished professor of psychiatry and the executive head of the Department of Psychiatry at Stellenbosch University. Her research focuses on gene-brain behavior interactions in trauma and PTSD, anxiety disorders, neuroAIDS, and fetal alcohol syndrome. She directs the SAMRC Genomics of Brain Disorders Research Unit and holds the South African Research Chair in PTSD, and she is a member of the ISTSS Board of Directors, and we are very, very lucky to have you as well.
Thank you for inviting me.
Dr. Jillian Shippard is a clinical research psychologist at the Women's Health Sciences Division of the National Centers for PTSD at VA Boston Healthcare System, and is a professor of psychiatry at Boston University School of Medicine. In addition, Dr. Shippard serves as the director for the LGBT Health Program at the Veterans Health Administration in Washington, D.C. Dr. Shippard's area of expertise is the interface of mental and physical health subsequent to trauma, with a focus on sexual and gender minority populations. And Jillian, it is truly a pleasure to have you as well.
Thank you so much. I'm happy to be here.
Great. I feel like I'm having this wonderful conversation with just dear old friends in front of an audience of 200 people, which is a delight. So let's dig into what I think is going to be a fascinating conversation for all of us. So just to start off, for those who aren't as lucky as I am in knowing a little bit about each of your work, can each of you tell us a little bit about your experiences in this area of research or clinical work? And on this one, I will pick on you because you all have to answer this question. So Juliet, do you want to start?
Sure. So my work in this area, really, you gave a great introduction in terms of my general area of research, where I look at the impact of racial stressors on health. And within that work, I also look at intersections, and I primarily focus right now on the intersection of race, ethnicity, and gender, and understanding how the experiences that people at those intersections, so for example, women of color, how their experiences may be different from the experiences of men of color or those with more privileged identities, in terms of how the types of stressors and the types of traumas they experience, how they respond to those, and how we can make sure that our treatment approaches are adapted and are culturally responsive, not only in terms of just culture or just race, but at the intersections of these different identities. And so some of the work I've done in that area has been, I'm right now looking at an intervention for race-based stress and trauma with veterans of color. And I'm looking at whether there are ways that we can sort of shape this intervention or adapt this intervention to be more responsive to the needs of women veterans of color. And so in order to do that, I'm evaluating these groups and running these groups in sort of mixed gender groups as well as women's only groups. And I'm trying to see if there are some things that the women benefit from more specifically within the women's groups, or if there is a benefit to being in the mixed gender groups, which I could also see as well. I also work in the women's trauma recovery team at VA Boston. And so I do some work with women veterans, and in particular, women veterans of color, and understanding how to integrate responsiveness to their intersectional identity also into evidence-based treatments for PTSD. So things like cognitive processing therapy. I'm also looking at whether there's sort of a distinct impact of discrimination on PTSD and other mental health outcomes within populations of color. And so seeing whether we see perhaps a more intense impact of discrimination on the mental health of Black women versus Black men or versus white men or women, for example, in more population-based quantitative research. So I'll stop there. Yeah.
Beautiful. We are very lucky to have your expertise here. It sounds like you're doing incredible work.
Thank you.
Soraya, shall I pick on you next? Would you be so gracious as to tell us all about the amazing work you're doing?
Yes, I'd like to highlight two strands of research that have really informed my thinking about social inequities as interlocking and unique. And in fact, I think that I have been sort of truly informed by interactions with colleagues in the workplace that fall outside of my research and clinical experience. This comes on the back of very frank discussions among colleagues about issues of race and ethnicity, gender, power, and privilege. And they have truly informed my thinking in the last 2 years. But prior to that, I have been involved in both sort of epidemiological and clinical work. And the first strand of research that I'd like to touch on is an epidemiological study known as the South African Stress and Health Study. That was a study that examined the psychological impact of apartheid and racial discrimination on South Africans. And as many of you would know, South Africa is a highly politicized society, and we had a long period of apartheid, which was systematized and institutionalized race-based exploitation and oppression of non-white South Africans. And even though apartheid was dismantled in 1994, its legacy remains in the form of racism, discrimination, other social and economic disadvantages, with the result that many, many South Africans are experiencing enduring psychological trauma. So this study really informed my thinking about racial versus non-racial forms of discrimination. And in this study, we examined acute and chronic racial and non-racial discrimination across all racial groups. And in South Africa, during apartheid, all South Africans were compelled to register into one of 4 official races. And these racial groups still persist, and approximately 90% of South Africans are Black. So unlike in the US, where Blacks are a minority grouping, Blacks in South Africa are majority grouping. And what we found at the time, which we examined approximately 6 or 7 years after the dismantling of apartheid, was that there was a more robust association between non-racial forms of discrimination relative to racial discrimination and a wide range of psychiatric disorders, so anxiety, mood, substance use disorders, which at the time was counterintuitive. We had expected that racial discrimination would be far more robustly linked with post-traumatic stress disorder and other stress-related disorders. And, you know, this raised my awareness of the need to better understand the differential mental health effects of racial and non-racial discrimination. And, you know, within the category of non-racial discrimination, also to think very carefully about disaggregating subtypes in terms of gender and sexual orientation. The second strand of research that I'd like to touch on is the intersection of HIV and trauma. And this is, you know, against the backdrop of South Africa carrying the largest share of the global HIV burden in the world. And this is an epidemic that disproportionately affects women and is highest amongst Black African women. So against this backdrop, there is also the very real issue of intergenerational trauma and the dynamic interplay between, on the one hand, past injustices under apartheid, and on the other hand, early childhood adversity and the current sort of very distressing contextual factors that many South Africans live under: poverty and cumulative trauma in the form of early childhood adversity and, intimate partner violence. So, you know, I've often thought about this in the context of the double hit, and I'm particularly interested in the interaction of sort of biological and environmental factors. And so the double hit for Black women in particular, in the context of the dual neurobiological impacts of HIV and the cumulative impacts of intergenerational trauma and current trauma on cognitive and neural and other neurobiological substrates. Thank you.
That was lovely. Thank you. And thank you for all of the incredible work you're doing, Soraya. Jillian, you want to give us a snapshot of what you're up to? You may be muted.
Thank you. I was saying these two are hard acts to follow, but I will do my best. So I have been working in the Veterans Health Administration since 2000 in the National Center for PTSD and the Associated Trauma Clinic for women veterans. And so by definition, for the past 20 years, I've been working in an intersectionality space because I've been working with women who are veterans, which is certainly a minority identity, and also that women veterans experience they experience the effects of marginalized identities because women veterans are more likely to be racially and ethnically diverse than their male counterparts. And women veterans are more likely to be sexual and gender minorities than their male counterparts. And so I love what Soraya was saying about the double hit. I feel like there is a synergistic impact of all these multiple minority identities that really speak to this issue of intersectionality. And so when I began working with women veterans in this context in the 2000s, I began to learn a bit about Black feminist theory, which, as I'm sure many of you know, in the US goes back to the 1800s with thought leaders like Maria Stewart and Sojourner Truth giving speeches about being both Black and a woman in the US in the 1800s. And I also was informed by the seminal work of Kimberle Crenshaw, who, as far as I can identify, was the first person to really talk about intersectionality in academic work. Her work back in 1989 and 1991 really helped to shape how I thought about trauma recovery work with women veterans, and really thinking about all these multiple identities. For those of you who are interested in Kimberle Crenshaw's work and the construct of intersectionality, I really encourage you to take a look at her review paper from 2014. And for those of you who like a little more visual sort of representation, she also has a TED Talk, so maybe that'll be more fun than an academic paper. So just some options for you. But the work that I was doing was sort of grounded in Black feminist theory and intersectionality. And then I began working with transgender veterans primarily in addressing their unique trauma recovery needs. And that's in 2012, I began the work at the national VA level, working on LGBT health policy and education. And I really began to think about the systemic impact of oppression on people's well-being and trauma recovery. And I know we'll be getting into talking about all of this a bit more later, so I'll stop there, but I have a lot of thoughts about that.
Jillian, also thank you for highlighting the seminal work in this area. Often we treat concepts as academics as if we've just discovered them. Like, look at us, aren't we amazing? And I think it's really important to center it in what are the roots of this and really who originated some of the early research and thinking and framing of these constructs. So, you know, based on your experiences, there have been a number of points that I've heard you all mention that I think are worth highlighting. The issue around syndemics, of how do you have various forms of discrimination, various stressors piling on each other, and then how that might increase or impact mental health and physical health disparities. As well as, you know, what happens when we try to put someone in one box and ignore the whole rest of their experiences. And that really came up as a theme from all of you. So I guess one question that I would have for each of you is how you see these intersecting identities shaping how people react to stressors or traumas and the kinds of stressors and traumas they experience. Who wants to jump in first, since I'm not going to pick on you?
I'll start.
Beautiful.
In thinking about how intersecting identities might shape how people react to stressors and traumas. So I'll sort of speak primarily to the intersection of race and gender. Or you can also think of it as race and sex as well, because I think a big part of what shapes how people respond to their experiences are the ways that they're socialized. And I think that there are very different ways in which girls and boys as children, and also as adults, women and men, are socialized in our society. And there are also ways in which that socialization, that gender socialization, intersects with race as well. and shapes the way that people are sort of expected to behave, the way that they're expected to express emotion, the way that they're expected to disclose or not disclose, the way they're expected to seek help or not. And I think if we think about, for example, the differences between Black men and women, for example, there are certain sort of stereotypes or expectations of Black women that differ very much from the expectations of Black men, and also differ from the expectations of white women. And so we can think about one like very common example is sort of this strong Black woman stereotype, and the way that that stereotype and that expectation of Black women sort of can, in a lot of ways, erase or minimize the suffering that Black women experience. And I think that that can have a very harmful impact on the ways that Black women expect themselves to sort of react to things like stress or trauma. I think there are other things such as the hypersexualization of Black women that occurs that shapes the way that not only women themselves react to their own victimization, but also the way that society reacts to Black women's victimization. And I think a really clear example of this is what happened with R. Kelly, and the fact that he was, essentially manipulating women into becoming and kidnapping and keeping women prisoner to be quote unquote sex slaves, and how that was viewed as, oh, well, they're choosing to be there, they want to be with him, he's a celebrity. And so that took sort of the attention and the impetus away from actually doing something about it until much later. And a lot of these women were actually girls and were underage, and he just went through a long period of time. And we can also think about the intersection here as well of race and class also, in that because he may have been a Black man, and we often think about Black men as being sort of over-policed, being harassed by the police often, having their behavior be more scrutinized. But in this case, because even though R. Kelly was a Black man, he's also somebody who is very rich and powerful in that way. And so that changes the dynamics of how people are viewed and how people respond to perpetrators as well as their victims. And so it brings up a lot of different questions for me. I think we're here to give some answers, but I think also it brings up a lot of questions because this research area is very nascent. And so there's a lot of work to be done. But some of the questions it brings up for me are, how do gender roles within the Black community, for example, or within the Latinx community, how does that shape how people respond to trauma? And can we do more research in that area so that we can really understand what are the main components that contribute to these differences and how people respond? How do Black women's frequent roles as multi-generational caregivers shape how Black women cope with stress and trauma? How does generational trauma shape coping? So we know that generational trauma has an impact on the way that people are socialized within their cultural groups, and also shapes the ways in which people respond to those traumas. And I think that those two areas are really important areas to continue to explore.
I love, Julia, that you highlighted how this panel may provide some answers, but it also may just highlight where we have lots of work to do. I think we may wind up with a lot of questions and maybe some general answers.
Yes.
Yeah. Also, I love that you were highlighting the strong Black woman theory, which for so long was touted as this: if you learn this theory, you will have cultural competence in treating trauma victims. And I'm so grateful that the field is moving away from this notion of cultural competence, which in my opinion has really reified stereotypes of various cultures and groups, and we're moving toward a construct of intersectionality and understanding an individual in their context and all the multiple identities that they hold. It's not accidental that trans women of color are dying at an inordinate rate, because they are so marginalized in our society. they are the ones who are victimized. And so, you know, these patterns are playing out, but we have not fully attended to them in the trauma recovery world. And I think we're starting to consider that.
Lovely. So anything else my panelists want to add to that question around how these intersecting identities shape the kinds of traumas that people are experiencing? So Jillian raised the very high rate of trauma exposure among women of color who are trans. Other issues that you all want to discuss in that area?
So I think that it's also important to think about, you know, microaggressions, because in those with marginalized identities, microaggressions are often directed at multiple identities simultaneously. And, you know, research has tended to either use a single axis framework by studying social identities independently, or using an additive or, you know, multiplicative approach, where, you know, you conflate social identities and assume that these identities and sexual orientation are in fact equal in their effects when they're not. And so an example of that is, you know, race and ethnicity, which is a kind of very visually distinguishable attribute that may affect, you know, an LGBT person of color's experiences more than their sexual orientation, which is a non-physical trait. And often that gets lost in research that doesn't take on an intersectional approach.
Oh, and Soraya, you gave me such a beautiful lead in to one of the questions I wanted to ask you all. Thank you. So, you know, one of the issues that can come up are around hidden identities. So, you know, sexual orientation, gender identity often are hidden, where a person has a choice, and often many choices around being out or not out. And that can also be true with racial or ethnic identity, depending on someone's physical appearance, for example, or presentation. How do you see those hidden identities changing people's experiences or impacting people as compared to identities that people don't have choices about in terms of how they present?
Yeah. I know you're not calling on people, but you know I'm going to jump right in on this one.
Well, and Julie, it is so hard for me to stay in a moderator role and not just chime in with my own opinions, but I'm staying in my lane.
Feel free. Well, you know, I think this issue of concealment and hidden identities comes up quite a lot, right? Particularly in the context of trauma work. Because certainly someone with a hidden identity can conceal their identity and potentially reduce the external stressors that they're exposed to. So maybe they're not getting beaten up in the street because they're expressing their gender identity or holding hands with their same-sex partner. But that comes at a cost. Right? So yeah, it can reduce the external stressors, but it increases the internal stressors. So it's going to increase feelings of guilt, shame, internalized homophobia or transphobia. And so it's got to be some part of a balancing act, right? So I think all coping strategies are good strategies in certain contexts. You know, you need to be flexible and have a lot of different coping strategies that you have available to you. And if this is one that you are choosing to use, there's nothing pathological about that. But, you know, it certainly can be adaptive in some contexts, but just recognizing that it does have a cost. Each strategy has a pro and a con to it, and this one is no different. So less trauma exposure potentially, but still negative health effects from the internal stress, I would say.
Lovely, thank you, Jillian. So I want to jump on a question that one of our audience members asked. We're starting to get some nice questions from the audience, thank you. So Tanya wanted to know about how you use the socio-political intersectional analysis in approaching trauma treatment? And I know this came up internally as we were thinking about what we wanted to talk about. How does this analysis inform how we approach patient care?
I will say that this is also sort of also addressing the first question that was related to the ways in which marginalized identities shape how people experience trauma. But I think one thing that is really important to mention is that marginalization also is structural and it's systemic. So it's not just about the fact that people experience maybe interpersonal discrimination or things like that, but it also shapes what people have access to. And it shapes the burden of stress that people experience. So the more marginalized identities people have, the more discrimination they experience, the more stress they experience, and that also shapes trauma. But within the context of trauma treatment, I think this is, again, something that needs to be explored more. But I will say it's important for any person who is working with somebody in treatment, any kind of treatment, and also trauma treatment, to really have a very deep understanding of oppression, systemic racism, white supremacy, intersectional oppression, all of these different forms of oppression that people may experience, in order to really be able to understand the dynamics of that individual's trauma. So for example, you may have a woman of color in trauma treatment for sexual assault, and there may be sort of racial and gender dynamics at play in her assault that can be overlooked if you're not if you don't have your mind in that space, so there may be ways in which, oftentimes we see with sexual trauma survivors, a feeling of self-blame, or I should have done something differently, or I shouldn't have done this, or I shouldn't have gone with that person. And oftentimes there really can be sort of racial dynamics involved in there. So I have worked with people who, the person that said, come with me, was a white man, and that person was a woman of color. And so there are these dynamics. And oftentimes if we overlook that or we don't address it, we lose an opportunity to really help the patient understand what was driving their behavior, sort of what led to them making the decisions that they made. And they're not always personal decisions, or I didn't think that through. A lot of times there are these broader dynamics that come into play with the individual. And if we don't have an understanding of how that might occur, then we miss out on that opportunity. So that's one thing I'll say, in one way that I try to bring in an understanding of these intersections into my work with patients with PTSD.
Absolutely. And I want to again highlight another thought leader in the area of systemic racism, Tricia Rose, R-O-S-E. She does a fantastic job of talking about structural racism and the effects of structural racism on people's health. She actually has a great YouTube out right now, How Systemic Racism Works During a Pandemic, which I think is really relevant to where we are right now. I think as a society, we're moving away from me, and thinking more about we in the pandemic mentality. And part of that is learning more about the systemic oppressions that exist. And really, I think as a provider, let's not just focus on, the treatments that we're delivering to individuals who come to see us for trauma recovery. Let's also talk about what are we doing as providers? What is our ethical and moral responsibility in terms of addressing systemic change, addressing systemic oppression? I think Soraya beautifully talked about this in the context of apartheid in her system of healthcare, and learning how to navigate that system and make change from within a culture that had been working under a particular framework for so long. We're starting to look at that a little bit more in our society now, which hopefully will make change. But I want us to be clear that trauma recovery is not just about what are we delivering to patients, but also what are we doing to change the system as providers behind the scenes, separate from the work in the room with the individual.
Absolutely.
And in line with what Vivian has said, I think it speaks to the issue of developing very specific social justice competencies as providers, which, as a clinician may be an uncomfortable fit. I think it is, about being knowledgeable and knowing how social inequities actually manifest at not just the individual level, but at societal level. And how they're experienced by different individuals and groups and organizations and macro systems.
And I would, sorry, go ahead.
Go ahead.
I'll add that in also thinking about delivering trauma or engaging in trauma treatment with individuals, I think it's also to really think about some of the unique culturally specific ways in which people experience trauma, or in which, race-related traumas impact people. So things like internalized racism, hopelessness, paranoia, cultural mistrust, all of these are elements that can come into play that are not necessarily things that we learn as much about in our training. And so it's important to really educate yourself around that. And then there are also culturally based strengths that we can draw on, like, spirituality, different aspects of empowerment that we can really focus on, and understanding collectivism and how that impacts people, and the importance of people connecting not just with their friends and family for social support, but also things that help them feel engaged with their cultural background can be very healing and very important for people. And then the last thing I'll say is it's also important to think about, especially when we're dealing with trauma that's related to racism, the ways in which, and this is true for for any kind of trauma treatment, but the ways in which vicarious trauma can occur for clinicians. And so if you think about a clinician of color treating a patient of color who's experienced racism-related trauma, trying to think about how that affects the clinician as well.
Those are lovely points. And Jillian, you also
Absolutely.
had some thoughts to add.
Yeah, Juliet, I think, did a beautiful job highlighting the resilience piece, which was what I was going to jump on, which is that, minority stress theory would argue that engagement in community through, whether that be through resistance, activism, political action, whatever it may be for that individual, that does lead to better health, that it can be a part of trauma recovery. And so working with your trauma survivor about how and when they engage with their community, and as Juliet said, not just their immediate friends and family, but how to heal through connection, I think is essential.
Nice. Well, I'm going to grab one of the questions from our listeners, but it also riffs off of some of the comments that you all have talked about, which is the current context that we all are in, which is a global pandemic, and how that has highlighted in many ways that the burden is being carried globally by marginalized communities. So if any of you are willing to talk about how transgenerational trauma, marginalization may actually be intersecting with the stressors associated with COVID-19 and the criterion A stressors in many ways that are associated with COVID-19, how do you see these as all fit together?
How much time do we have?
Well, we probably have about 10 more minutes for this. I'm looking at the questions coming in from the audience, the questions that are coming in the chat box that I'm not monitoring because I'm not looking at the chat box for Q&A, and the questions I had, and it feels like we could have like 3 more of these. This is just a really fun conversation.
Yeah, I agree. And I think this falls into, I think we have more questions than we have answers, I've never lived through a global pandemic before. I don't have anything to draw from. I think there are lessons learned from 1819, but, we didn't have as developed a trauma recovery field then, so there's no real literature to turn to. I'm sure others have important things they could share, though.
I mean, I think, again, it goes back to the fact that even outside of a pandemic, the burden of stress in our society rests on the shoulders of marginalized people. And so oppression operates in so many different ways. I mean, it shapes where people can live, their access to safety and health promoting resources like health insurance, healthcare, education, walkable neighborhoods, you know, every single aspect of life, their ability to receive professional help and protection from the state, to name just a few. And so because of this, you know, those factors shape the kinds of traumas people are exposed to and the stressors they experience. And when we have this sort of global pandemic that's affecting all of us, right? So we all know how stressful this is. But then we think about people with marginalized identities, you know, let's just say they have one marginalized identity, and how let's say they're a Black man, Black, cisgender, heterosexual man, and we've seen how this pandemic has had such a disproportionate effect on that population. But then think about somebody having another marginalized identity, and then another one, and then another one, and how, you know, we add the burden on top, so that the more of these sort of global, long-lasting, persistent, chronic stressors that people experience, the more vulnerable they are to experiencing mental health problems, the more vulnerable they are to experiencing physical health problems. You know, stress actually increases increases vulnerability to even catching a virus. So it's not just that people have underlying conditions that make them more likely to die from the virus, they're actually more likely to just get the virus because of stress. And so I think a lot of when we think about PTSD and trauma, we also really have to think about stress and the ways that it makes people more vulnerable to the impacts of traumas and perhaps less likely to recover from trauma. And perhaps there needs to be a slightly adapted or different approach to trauma treatment in order to be able to also take into account the impact of all those other stressors that people are experiencing on a daily basis.
Right. And let's not forget that our marginalized populations are the ones who are doing the frontline work. They're often the ones who are cleaning in the hospitals. They are the ones that are who don't have sick leave that they can take, who can't telework. You know, those kinds of class-based issues are impacting exposure to the virus as well. Not just the allostatic load from all the stressors.
And then you add on top of that the racism epidemic that's coming to the fore, and that is on top of itself a whole other stressor for people with marginalized identities.
Absolutely. This certainly resonates with Soraya, what you were talking about in your introduction, about all the tremendous work that you've done around HIV and also around fetal alcohol syndrome, which are other places where you can see marginalized communities really bearing the burden of both the physical effects and psychiatric effects of medical conditions and stressors.
Yeah, and the pandemic has truly highlighted the disparities in access to care, because the majority of HIV infected patients and patients with tuberculosis have not been able to access care in the public health sector. So, you know, only 15% of the South African population can afford private health care. And so for those patients and patients with other chronic non-communicable diseases, this pandemic has drawn the lines between the haves and the have-nots in a very stark way.
Beautiful. Well, this is certainly a conversation where the time is going like that. There's a couple more questions from the audience that I'm hoping we'll have time to answer. You know, one that came up that I think is quite interesting, and Jillian, it ties in with some of the work that you talked about in the beginning, is the role of us as professionals, as mental health professionals, around making these policy changes, around advocacy, around how are we forces for social justice change. And Julia, you spoke about this as well a bit.
I did. I feel very strongly about this personally. I believe it is an ethical imperative as psychologists. It falls under our ethical responsibilities as providers to be engaging in systemic change. I personally don't see how somebody could not be engaged at any level and then go into a session with somebody who has been the victim of oppression, and, you know, with a clean conscience, work with them on you know, developing coping mechanisms for the stress that they've experienced, if you're not also trying to help prevent the harms. But that's just my personal opinion.
I would say it's probably not just psychologists. It probably includes other providers like psychiatrists.
I mean, I think that the beautiful thing about psychology is that it's all about behavior change. And a lot of what we need in the field of psychology is some change. And I think that there's, I mean, I could talk about this all day, but, you know, a couple of things I'll say is, one is that psychology really focuses on the individual. And this is really important, but it's also important to understand that the individual lives within a context and to be able to integrate that within the way that we approach treatment. That's a really important point. The other important point, and that connects to that, is critical consciousness. So this idea of understanding the dynamics of oppression and how they operate in our society and how they impact the individual. And, you know, we can do that on our own, but I think it's something that really needs to be integrated within training as it stands. And then the last thing I'll say is that for me, something that I find to be very helpful in terms of advocacy is public education and engaging with people, not just through writing grants or writing research papers, but engaging with people. Somebody said, now you're talking like a social worker. I do that sometimes, but engaging with people and
lots of disciplines.
Yeah,
learn from all the disciplines.
Yeah, and talking about these issues in a more accessible way, so that it's not just, and also that also helps people who maybe are patients know what to look for, you know, and know what good treatment should look like for them. So I think that there's a really important role of public education in helping to push the field forward and move things in the direction, you know, of the future.
One way to address this would be to look at psychology trainees and psychiatry residents getting experience in community-based social justice settings, because I think it could also contribute to their abilities to self-reflect on issues of race and ethnicity and oppression and power and privilege in their own lives, and to develop the competencies that are needed in treating patients in an intersectional way.
That's a really, really important point, Soraya.
That would be wonderful.
Yeah, yeah. So, you know, one of the questions that came up as well for the audience, I'm going to shape your question a little bit, Debra, is around how do we bring trainees into this, right? So whether it's psychiatry residents, social work students, new psychologists, how do we actually teach them well around addressing intersectionality as they're launching into their clinical careers?
I mean, I think we need more. There's again a lot, but one thing is, like, we need to really push to increase the representation of people with intersectional identities within the field of psychology. So we need more women of color, trans women of color, trans people of color. We need more, you know, we need more people who represent the identities of the people that we're serving, and also people who are coming from a more ecological and holistic perspective, or want to really learn in that area. So I think that representation is a really big part of this, because if people have supervisors who are well equipped to teach them how to engage in culturally responsive therapy and taking an intersectional approach, then those therapists working with those supervisors are going to be more well equipped to do that. So I think that that's one really big area that we need to work on.
I could not agree more. And so what I would say about that is that begins not with you know, students of color who are graduate students, that begins in, you know, very, very young education, like K through 12, making sure that there is, there's a shift in our educational system that helps to guide marginalized populations to our profession. I really believe that there is a bottleneck because of systemic issues. And here again is another opportunity, I think, as psychologists, to work on change in the system so that our profession can continue to grow.
If I can add in one point, I'm sorry, it's so hard to stay in the moderator role the whole time. You know, I think also there's a tremendous responsibility on those of us who might be a little more senior in the field, as much as I cringe saying that, to create a safe and welcoming environment for our trainees where they can talk openly about the experiences, where they can get the support they need to survive, and to really be reflective of, are we being good about making sure that everybody is getting access to training materials, to support, to opportunities in a way that helps grow this next generation that is more diverse and needs to be more diverse.
And as a longer term objective, perhaps to ensure that there's mentoring of trainees so that they can continually, you know, examine their own sort of ethical judgment and decision-making styles when they work with clients from diverse groups.
Yeah, of course. Diverse groups always come to a better answer. There is an abundance of literature to support that. That is no longer an empirical question. And so how can we get to that place within our field?
And I think something that people can do today who are in the field who do mentor people, if you have a mentee who is a person of color or comes from another marginalized groups and you don't connect with them on that, you don't look like them or you don't share that identity, connect them with a mentor who does share that identity, who might be willing, you know, who is willing to sort of mentor them in the capacity of how do you survive in this discipline, you know, with these identities that are marginalized and often ignored or set aside. And I think that that can just be such an enormous source of support. I mean, I know when I've had like an hour conversation with a mentor like that, it just changes, it just makes me feel like I can do this, you know? And so that's something people can do right now.
Yeah, and oh, can I add one?
Sorry. Yeah, go for it.
I mean, the other piece that I think you all bring up is also the importance in supporting junior faculty. I think one of the challenges for individuals who are more diverse is they also wind up carrying a heavier committee load, often a heavier mentoring load, because they are trying to carry this for so many and they have these extra burdens. Yeah, absolutely. And then often those activities are not valued in our academic system in the same way that other types of activities are valued. And how do we help them?
Yeah, thank you for bringing that up, because as someone who is trying to encourage and support junior faculty who come from marginalized communities, you know, first and foremost, I come to that work being humble about what I don't know, because that is vast, certainly. And I will never know what it's like to be in the position of another marginalized individual. And so from my place of great privilege, I can do some things, but there are many things that I cannot. So Juliet brought up a great point of having a mentor from a similar background or similar community can be helpful, but also you know, we cannot, as people who own a lot of power, we can't sit back and say, oh, we're going to let the marginalized communities fix this problem. We made the problem. We have to be a part of the solution. And so making sure that the burden doesn't fall disproportionately on marginalized communities is really important.
That was lovely. So I don't know that we have time to do any more questions, and I feel sad about that because we have a number that we have answered. We have some that came up in the chat box that we didn't address and other ones that we just couldn't have time to address. This really sounds like an opportunity to either have further discussion at an annual meeting or to have follow-up around this. I just want to say a couple of comments in closing. I think that this panel has highlighted just the vast importance of this group and of this conversation in addressing these issues to improve research, to improve clinical outcomes, to improve policy, and to make a better world. And thank you to all three of you for the incredible efforts that you all are doing to try to get to those places, to make it a little bit better, and in growing our next generation of researchers and clinicians and academics and policymakers. I also, again, want to do a shout out to our fantastic SIG for organizing and hosting this event. Yeah, absolutely. And showing tremendous initiative. This was entirely the brainchild of the SIG. If people are interested in these topics and these conversations, I would encourage you to come to the ISTSS annual meeting. The meeting theme this year is around health disparities. And so I do think that there will be similar kinds of conversations that we hope to foster at our annual meeting. We also have some tremendous keynote speakers who will be talking about issues around, for example, global mental health and around health disparities and reaching underserved communities. In terms of the SIG, if individuals are interested in the SIG, please feel free to join our SIG by emailing any of the co-chairs, Lindsay Zimmerman, Ruby Charnak, or Laura Wilson. Again, I want to thank you all for your hard work in organizing this, and for everyone who's attending. People are balancing so many roles and so many responsibilities right now, and for you to give us an hour of your day or evening, it is deeply, deeply appreciated. So thank you so much. Any last comments from the panelists?
Thank you for having us.
Yes,
Thank you very much. And thank you, Deborah, for chairing so efficiently.
I was mostly well behaved, which is about the best you'll ever get.
Mostly.
I have one last comment, and that is that when we think about intersectionality, this is such an important conversation, because usually when we focus on any kind of, like, if we think about these movements that we're in, Black Lives Matter and the feminist movement in the past, often those movements focus on the most privileged within that group. So when we think about a Black movement, we think about really about Black men. When we think about a women's movement, we really think about white women. So it's going to be imperative for all of us to focus explicitly on those intersections. We have to really focus on the intersections in order to get them the attention and the focus that they need. So I encourage everyone to really think about that.
Very nice point. Thank you, Juliet.
Thanks, everyone.